Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Hey, future nurses! Welcome once again to Stan Coast NCLEX, your trusted learning space where nursing knowledge meets confidence and clarity. We upload 2 to 3 powerful NCLEX videos every single day, each one crafted to strengthen your critical thinking, sharpen your clinical judgment, and boost your exam success. Today's high-yield topic focuses on nursing care of clients with inflammatory and allergic disorders of the upper airways. In this essential lesson, we will explore conditions such as rhinitis, sinusitis, pharyngitis, and tonsillitis, along with allergic reactions like hay fever and nasal polyps. You will learn the pathophysiology, key assessment findings, diagnostic procedures, and evidence-based nursing interventions that promote airway patency, comfort, and client safety. We will also discuss client education, medication therapy, and preventive strategies that play a vital role in long-term respiratory wellness. So, stay tuned and keep your notes ready, because every second here takes you closer to mastering the NCLEX. And remember, at Stan Coast NCLEX, we do not just teach nursing, we build nurses who think, care, and lead. Let's begin this insightful journey into upper airway inflammatory and allergic disorders. Let me share something before we jump in. Something that's changed how thousands of nursing students prepare. When over 100,000 students use the ultimate NCLEX crash course, they didn't just study, they succeeded. Why? Because this course gives you everything. Engaging live classes, 5,000 NCLEX-style questions, 30 full mock exams, ebooks, and NGN practice explained like never before. It's the complete blueprint for your success. Take a moment now. Scan the QR code or click the link below to enroll and unlock free resources, quizzes, and PDF notes. Plus, our Telegram and WhatsApp groups will keep your motivation sky high until you pass. Moving ahead with first clinical scenario, imagine a nurse preparing to obtain a throat culture from a client admitted with acute pharyngitis and fever. The nurse must ensure correct specimen collection for accurate microbiological diagnosis. Here are the options to consider. The first option suggests asking the client to expectorate sputum into a sterile container. The second advises wiping the client's inner cheeks and tongue with a sterile gauze pad. The third recommends swabbing the tonsillar areas and posterior pharynx using a sterile cotton applicator. And the fourth involves collecting the client's saliva in a sterile culture cup. The correct answer is option 3, swab the tonsillar areas and posterior pharynx using a sterile cotton applicator. When we look closely at the expanded advanced rationale, pharyngitis, an inflammation of the throat commonly caused by Streptococcus pyogenes, or other organisms, requires accurate specimen collection to identify the pathogen responsible and to guide antibiotic therapy. To ensure accuracy, the nurse must use a sterile cotton-tipped applicator to gently swab the posterior pharynx and tonsillar pillars while avoiding the tongue, cheeks, or teeth, as these areas contain normal oral flora that can contaminate the specimen. The posterior pharyngeal wall harbors the highest concentration of pathogenic organisms in cases of streptococcal infection, making it the ideal site for collection. Once the swab is taken, it should be immediately placed into a sterile transport medium and sent to the laboratory within 30 minutes to prevent bacterial overgrowth or drying. Additionally, the nurse should explain the procedure to the client to reduce anxiety and gag reflex, asking them to tilt the head slightly back, open the mouth wide, and say, "ah," to elevate the soft palate for better visualization. Now, let us understand why the other options are incorrect. Option 1, asking the client to expectorate sputum into a sterile container, is inappropriate because sputum comes from the lower respiratory tract and is used to diagnose conditions like pneumonia or tuberculosis, not pharyngitis. Option 2, wiping the tongue or cheeks with gauze, primarily collects saliva and harmless oral organisms, leading to false results. Option 4, collecting saliva in a sterile cup, is also unreliable since saliva lacks the pathogenic organisms that cause throat infections, making the culture diagnostically useless. Transitioning to the Stancoast clinical insight, it is essential to remember this key principle. Accuracy begins at the source. A single misplaced swab can turn a correct diagnosis into a missed opportunity. Proper specimen collection is the foundation of evidence-based infection management, and nurses play a vital role in ensuring that results are both valid and timely through correct technique and prompt transport. Moving on to the Stancoast high-yield NCLEX Pearl, always remember to swab the posterior pharynx and tonsillar pillars using sterile technique before starting antibiotic therapy. Additionally, advise clients to avoid eating, drinking, or using mouthwash immediately before specimen collection to prevent dilution or contamination, ensuring a precise and reliable diagnostic outcome. Let us move into another crucial NCLEX scenario that highlights the importance of antibiotic adherence. A client diagnosed with a throat infection caused by group A beta hemolytic streptococcus, also known as Streptococcus pyogenes, is prescribed oral potassium penicillin V, commonly known as V-Cillin K. During discharge teaching, the nurse emphasizes that the client must complete the full antibiotic course. The question asks, failure to complete the prescribed therapy can lead to which serious complication? Here are the options to consider. Option A suggests glomerulonephritis. Option B mentions chickenpox. Option C refers to shingles. Option D indicates whooping cough. The correct answer is option A, glomerulonephritis. To understand why, let us explore the expanded advanced rationale. Group A beta hemolytic streptococcus is responsible for streptococcal pharyngitis, tonsillitis, and scarlet fever. While these infections initially affect the throat, inadequate treatment can trigger serious post-streptococcal complications, such as acute glomerulonephritis, rheumatic fever, and rheumatic heart disease. These conditions result from immune-mediated cross-reactivity, where antibodies produced against bacterial M proteins mistakenly attack the body's own tissues. When the infection is partially treated or antibiotics are stopped prematurely, residual bacterial antigens stimulate this autoimmune reaction. In the kidneys, it causes inflammation of the glomeruli, leading to hematuria, proteinuria, periorbital edema, and hypertension, hallmarks of post-streptococcal glomerulonephritis. In the heart, similar immune responses can damage the valves and myocardium, resulting in rheumatic fever with symptoms such as migratory arthritis, carditis, and chorea. To prevent such complications, the American Heart Association, AHA, strongly recommends completing a full 10-day course of oral penicillin V or erythromycin for allergic patients. Penicillin eradicates Streptococcus pyogenes and halts further antigenic stimulation. Even if the throat feels better after a few days, stopping antibiotics early allows bacterial survival, leading to dangerous immune activation weeks later. Now, looking at why the other options are incorrect, option B, chickenpox, is caused by the varicella zoster virus, not bacteria, and antibiotics have no role in viral infections. Option C, shingles, is a reactivation of the same varicella zoster virus in adults, unrelated to streptococcal infection. Option D, whooping cough, results from Bordetella pertussis, a gram-negative bacterium requiring macrolide antibiotics, not penicillin V, and is completely unrelated to streptococcal throat infections. Transitioning into the Stancoast clinical insight, here is an essential reminder. Every incomplete antibiotic course is a silent invitation to autoimmune disaster. Post-streptococcal complications are preventable, not inevitable. Teaching patients to finish their medication is one of the simplest yet most life-saving nursing interventions to protect both kidneys and the heart. Moving forward with the Stancoast high-yield NCLEX Pearl, always educate clients to complete their antibiotic course even if symptoms subside within 2 or 3 days. Explain that early discontinuation can trigger rheumatic fever or glomerulonephritis long after recovery from the sore throat. Encourage adequate hydration, advise monitoring for hematuria or joint pain, and use written reminders for adherence. Remember this NCLEX cue: unfinished antibiotics lead to autoimmune aftermath. Let us continue with another crucial NCLEX-style clinical scenario that highlights infection control precision and evidence-based nursing practice. A nursing home resident has just been admitted to the hospital for evaluation and treatment, and as part of standard infection control protocol, the nurse must obtain a nasal swab to screen for methicillin-resistant Staphylococcus aureus (MRSA) colonization. The question asks, which nursing action demonstrates correct technique for collecting the specimen? Here are the options to consider. Option A says to don sterile gloves before obtaining the specimen. Option B suggests inserting the swab into the anterior portion of the nair and rotating it along the nasal mucosa. Option C recommends instructing the client to blow the nose before the specimen is collected. And Option D advises using a separate applicator for each nair. The correct answer is Option B: insert the swab into the anterior portion of the nair and rotate it along the nasal mucosa. Now, let us explore the expanded advanced rationale to understand why this option is correct. MRSA is a particularly resistant strain of Staphylococcus aureus that represents a major infection control concern across healthcare facilities. Since the nasal cavity is the most common reservoir for MRSA colonization, hospitals routinely perform nasal swab screening at admission, particularly for high-risk individuals such as nursing home residents, dialysis patients, and those with chronic wounds or a history of MRSA infection. The correct collection technique involves gently inserting a sterile swab about 1 to 1.5 centimeters into the anterior nares and rotating it against the inner nasal walls for several seconds. This motion ensures contact with the nasal mucosa, where MRSA organisms typically reside. The same swab is then used for the opposite nostril before placing it into a transport medium for culture or polymerase chain reaction testing. Regarding glove use, nurses should wear clean, non-sterile gloves rather than sterile gloves because the procedure involves contact with mucous membranes, not a sterile site. This aligns with standard precautions and prevents both contamination and accidental self-inoculation. In terms of client preparation, asking the client to blow their nose before collection is unnecessary and may actually reduce bacterial presence, leading to inaccurate or false negative results. It is more effective to simply explain the procedure, ensure comfort, and minimize anxiety during specimen collection. Using one swab for both nares is also correct, as MRSA colonization tends to be bilateral, and using two separate applicators would increase cost without improving accuracy. From an infection control perspective, identifying MRSA carriers early is vital because colonization, even without active infection, increases the risk for subsequent complications such as surgical site or bloodstream infections. Early detection allows healthcare teams to implement contact precautions, cohort MRSA-positive patients, and initiate preventive measures such as intranasal mupirocin ointment or chlorhexidine bathing regimens. Transitioning to our clinical insight, here comes the Stancoast clinical pearl. Every swab collected for MRSA screening is more than a laboratory task. It is an act of infection prevention that protects every patient, staff member, and visitor from a potential outbreak. And now for the Stancoast high-yield NCLEX pearl. Always remember that proper MRSA nasal swab collection requires clean gloves, gentle insertion into the anterior nares, rotation along the nasal mucosa, and use of the same swab for both nostrils. Never instruct the client to blow their nose before sampling, as it can remove surface bacteria and compromise test accuracy. Moving on to another important clinical situation that tests both communication and evidence-based nursing care, let us look at this next scenario. A client calls the outpatient clinic reporting persistent hoarseness and throat discomfort and requests an appointment for evaluation later that morning. While waiting to be seen, the client asks the nurse for advice on symptom relief. Which nursing instruction is most appropriate to give in this situation? Here are the options to consider. Option A says, suck on ice chips to relieve throat discomfort. Option B suggests, rest your voice as much as possible. Option C recommends, drink plenty of hot liquids to soothe the throat. And Option D advises, massage your throat to promote comfort. The correct answer is Option B, rest your voice as much as possible. Let us now explore the expanded advanced rationale behind this correct response. Laryngitis refers to inflammation of the laryngeal mucosa and vocal cords, commonly caused by viral infection, excessive voice use, or exposure to irritants like smoke or allergens. The hallmark symptom is hoarseness or even loss of voice due to swelling of the vocal cords. The most crucial intervention is complete vocal rest, because it allows the irritated vocal cords to heal without continuous vibration or trauma. Interestingly, whispering, often assumed to be gentle, actually increases strain on the cords and should be avoided. Therefore, the nurse must emphasize complete voice rest, nonverbal communication, and avoidance of throat clearing, which worsens irritation. Hydration supports recovery by keeping secretions moist, and the use of steam inhalation or humidified air can further relieve discomfort. However, these methods do not directly reduce vocal cord inflammation. Similarly, saline gargles or throat lozenges can soothe the surrounding mucosa, but provide only symptomatic relief. Unless bacterial infection is confirmed, antibiotics are unnecessary. With proper care, recovery typically occurs within 3 to 7 days. Now, let us understand why the other options are incorrect. Option A, which suggests sucking on ice chips, may briefly relieve throat discomfort but does not reduce inflammation of the larynx because the cooling effect does not reach the vocal cords, which are located deeper. Option C, recommending hot liquids, can actually aggravate inflammation and worsen mucosal irritation. Instead, warm or cool fluids are safer choices. Lastly, option D, massaging the throat, provides no therapeutic benefit and may even increase local irritation, since the larynx is a delicate internal structure not accessible through external manipulation. Transitioning to an important takeaway for clinical reflection, here comes the Stan Coast clinical insight. Resting the voice is not just silence. It is active healing for the vocal cords. Every whisper avoided is one step closer to restored tone and strength. And to conclude with a crucial exam-focused reminder, here is the Stan Coast High-Yield NCLEX Pearl. When educating clients with laryngitis, emphasize the importance of total voice rest, adequate hydration, humidified air, and avoiding irritants such as smoke, alcohol, or excessive coughing. Persistent hoarseness lasting more than 2 weeks requires further evaluation to rule out chronic irritation, vocal cord nodules, or laryngeal malignancy. Hey, wait a second. Before you scroll, I've got something that could totally transform your NCLEX journey. If you're serious about passing on your very next attempt, the Ultimate NCLEX Crash Course is your golden ticket. Trusted by over 100,000 nursing students, it's the all-in-one solution that makes your prep faster, smarter, and stress-free. You'll get interactive live sessions, 5,000 exam-style questions, 30 full-length mock tests, ebooks, PDF notes, and NGN breakdowns explained step by step. It's not just another review. It's everything you need in one powerful system. Scan the QR code or use the link in the description right now to enroll instantly and unlock free notes, practice tests, and NCLEX quizzes. You'll even get access to our Telegram and WhatsApp channels packed with daily free resources. Let us now move to an important clinical reasoning scenario that focuses on communication and diagnostic understanding. After 2 weeks of conservative management for laryngitis, a client still complains of persistent hoarseness. The physician therefore schedules a direct laryngoscopy to explore the underlying cause. The nurse evaluates the client's understanding and asks what they believe this test is for. Which of the following statements indicates that the client truly comprehends the rationale behind this procedure? Here are the options to consider. Option A states, the test will tell if my hoarseness is caused by tracheal polyps. Option B says, the physician says that hoarseness can lead to bronchitis. Option C mentions, I need to have the test because hoarseness can be a symptom of laryngeal cancer. And option D adds, the physician wants to see if my hoarseness is because of enlarged tonsils. The correct answer is option C. I need to have the test because hoarseness can be a symptom of laryngeal cancer. Now let us carefully examine the expanded rationale behind this response. Persistent hoarseness that lasts for more than 2 weeks always warrants further evaluation because it may be an early manifestation of laryngeal cancer. This is especially critical for individuals with known risk factors, such as chronic smoking, heavy alcohol use, or occupational exposure to irritants like asbestos or industrial fumes. A direct laryngoscopy is a diagnostic procedure performed under anesthesia that allows the physician to directly visualize the larynx, vocal cords, and surrounding mucosa using a rigid or flexible scope. Unlike indirect visualization, this method provides a clear and magnified view of suspicious lesions, nodules, or masses. Importantly, if any abnormal tissue is seen, a biopsy can be obtained immediately for histopathological confirmation, making this procedure vital in detecting malignancy at an early stage. The American Cancer Society emphasizes that a nagging cough or hoarseness is one of the 7 early warning signs of cancer. Therefore, recognizing and acting upon persistent hoarseness can lead to earlier diagnosis and potentially life-saving interventions. Other clinical manifestations of laryngeal carcinoma may include difficulty swallowing, shortness of breath, unexplained weight loss, neck mass, persistent sore throat, or referred ear pain due to shared cranial nerve pathways. Early diagnosis through laryngoscopy allows for organ-preserving treatment options such as radiation therapy or limited excision instead of total laryngectomy, thus preserving the client's ability to speak. Moving on to the incorrect responses. Option A, which refers to tracheal polyps, is inaccurate because these growths are rare and typically cause coughing or airway obstruction, not isolated hoarseness, as the trachea lies below the larynx. Option B is incorrect since hoarseness does not cause bronchitis. The two may coexist from a common viral infection or irritant exposure, but one does not lead to the other. Option D, suggesting enlarged tonsils as the cause, is also incorrect because the tonsils belong to the oropharynx and do not influence vocal cord vibration. Enlarged tonsils cause sore throat, dysphagia, and a muffled, hot potato voice, but not true hoarseness. Transitioning to the deeper clinical takeaway, here comes your Stan Coast. Clinical insight. Persistent hoarseness is not simply a throat symptom, it is a warning sign from the larynx itself. Prompt referral for laryngoscopic evaluation can determine whether the cause is benign or malignant. An early detection can often mean the difference between a minor excision and a complete loss of voice. And now for the Stan Coast High-Yield NCLEX Pearl. For both NCLEX success and safe nursing practice, remember to report any hoarseness that lasts more than 2 weeks. Educate clients that early medical evaluation significantly improves outcomes and may preserve speech and airway integrity. Encourage smoking cessation, good hydration, and avoidance of vocal strain as essential preventive measures. Now, let us move into a common yet clinically significant scenario that tests your understanding of medication side effects. A 23-year-old client reports that every autumn they experience nasal congestion, frequent sneezing, and itchy, watery eyes. The allergist diagnoses seasonal allergic rhinitis and prescribes diphenhydramine, commonly known as Benadryl, a first-generation antihistamine, for symptom relief. The question asks, which adverse effect should the nurse emphasize when educating the client about this medication? Here are the options to consider. Option A, weight loss. Option B, constipation. Option C, drowsiness. And Option D, depression. The correct answer is Option C, drowsiness. To understand why, let us explore the expanded advanced rationale. Seasonal allergic rhinitis is an immunoglobulin E-mediated hypersensitivity reaction triggered by environmental allergens such as pollen, dust, or mold. When these allergens are inhaled, mast cells release histamine, causing vasodilation, capillary permeability, and glandular stimulation that lead to sneezing, nasal congestion, and itchy eyes. Diphenhydramine acts as a first-generation H1 receptor antagonist, competing with histamine to block these effects. However, because this drug is lipophilic and crosses the blood-brain barrier, it also interacts with central histamine receptors, producing significant sedation and psychomotor impairment. This central nervous system depression explains why drowsiness is the most frequent and clinically important adverse effect. The nurse should advise the client to avoid driving, alcohol intake, or operating machinery until they know how their body responds. Drowsiness can become more pronounced when diphenhydramine is taken with other central nervous system depressants, such as opioids, benzodiazepines, or alcohol. Although mild anticholinergic effects like dry mouth, blurred vision, urinary retention, and constipation can occur, these are generally less severe than sedation. Clients who require daily allergy management should consider second-generation antihistamines, such as loratadine, cetirizine, or fexofenadine, which provide relief with minimal sedation because they do not readily cross the blood-brain barrier. Turning now to why the other options are incorrect. Option A, weight loss, is inaccurate because diphenhydramine may actually increase appetite and cause slight weight gain due to its effect on the hypothalamic appetite center and reduced activity levels. Option B, constipation, while possible due to anticholinergic effects, is not the primary or most notable side effect of first-generation antihistamines. Option D, depression, is also incorrect because diphenhydramine primarily produces sedation rather than mood alterations. Any emotional dullness is secondary to slowed central nervous system activity, not true depressive disorder. Transitioning into the Stan Coast clinical insight, remember this key nursing wisdom. Every antihistamine can calm the sneeze, but the first-generation ones calm the mind too. Drowsiness is a dose-dependent central effect that can quietly turn therapeutic relief into a safety risk if the client drives, works at heights, or operates machinery. And moving finally to the Stan Coast high-yield NCLEX Pearl, keep this high-yield fact in mind. First-generation antihistamines cause sedation, dry mouth, blurred vision, and urinary retention, while second-generation antihistamines provide longer action with minimal sedation. Teach clients to take the drug at bedtime to reduce daytime sleepiness, and always avoid alcohol or other depressants to prevent excessive sedation. Let us move into another clinically relevant question that highlights the importance of accurate diagnostic reasoning in allergy management. A client diagnosed with recurrent seasonal allergies is advised by the physician to undergo allergy skin testing. The client curiously asks the nurse, "Why do I need this test when I already know I have allergies?" Here are the options to consider. Option A says, the symptoms may be related to more than one substance. Option B states, skin testing helps to build up blocking antibodies. Option C mentions, allergic responses vary from person to person. And option D adds, the allergy symptoms could become more serious. The correct answer is option A, which states that the symptoms may be related to more than one substance. Now, let us explore the expanded rationale in detail. Allergy skin testing is a fundamental diagnostic procedure that identifies the specific allergens responsible for triggering hypersensitivity reactions. The correct response, option A, highlights that a client's symptoms can stem from multiple allergens rather than just a single source. Many individuals with atopic tendencies are polysensitized, meaning they may react to various allergens like pollen, dust mites, molds, pet dander, or even certain foods. Detecting all causative allergens enables healthcare providers to design a personalized management plan and recommend targeted immunotherapy or avoidance strategies for improved outcomes. Option B is incorrect because skin testing is not a therapeutic intervention. It does not build blocking antibodies. Instead, it simply determines which allergens trigger an immediate immunoglobulin E-mediated hypersensitivity reaction. The creation of blocking antibodies, known as immunoglobulin G, occurs during allergen immunotherapy, a treatment that progressively desensitizes the immune system over time. Option C, while partially true, does not justify the purpose of skin testing. Although allergic responses indeed differ among individuals due to genetic and environmental factors, this explanation does not clarify why the test is conducted. The test's goal is to pinpoint specific allergen sensitivities, which is essential for targeted management. Option D is also not the right rationale. Allergy testing is not primarily ordered because symptoms could worsen, but rather to identify causative allergens for effective treatment and prevention. Although uncontrolled allergies may become more severe, that is not the reason the test is performed. In clinical practice, allergy skin testing involves different methods such as the prick or puncture test, intradermal test, and patch test. The most commonly used skin prick test detects immediate hypersensitivity reactions within 15 to 20 minutes, typically presenting as wheal and flare responses. Nurses play a key role in this process by instructing clients to avoid antihistamines for 48 to 72 hours before testing, as these medications can suppress reactions and lead to false negatives. Post-procedure, vigilant monitoring is necessary for systemic effects like urticaria or anaphylaxis, and emergency epinephrine should always be available during testing. Transitioning now to the Stan Coast clinical insight. Every sneeze tells a story, but only skin testing reveals the true culprit. Identifying each allergen allows nurses to guide clients beyond mere symptom control toward long-term management and prevention. Moving forward to the Stan Coast high-yield NCLEX Pearl, allergy skin testing detects specific immunoglobulin E-mediated hypersensitivity reactions. clients must discontinue antihistamines before testing to prevent false negative results. This test helps identify multiple allergens, supporting a personalized treatment approach. Finally, nurses should always remain prepared for potential adverse reactions by keeping emergency supplies close at hand. Hold on, don't skip this, because what I'm about to share could be the difference between passing and retaking your NCLEX. The ultimate NCLEX crash course, trusted by over 100,000 nursing students, gives you a fast track to success. Imagine having everything: live and recorded lectures, 5,000 exam questions, 30 practice tests, ebooks, PDFs, planners, and NGN deep dives, all in one place. This is your shortcut to confidence and clarity. Scan the QR code right now or click the link to enroll and unlock free notes, quizzes, and exclusive NCLEX test sets. You'll also get instant access to our Telegram and WhatsApp learning groups filled with daily tips and free resources. Moving forward to another insightful clinical situation, let us examine how nurses interpret allergy skin testing results. During a scratch skin test on a client suspected of multiple environmental allergies, the client curiously asks, "How will you know if I am allergic to any of these substances?" Now let us carefully go through the options together. Option A says the skin at the test site feels numb. Option B states the skin at the test site feels painful. Option C mentions that the skin at the test site looks pale. And finally, Option D indicates that the skin at the test site looks red. The correct answer is Option D, which says that the skin at the test site looks red. Now, here's the detailed explanation behind this finding. Allergy skin testing, including the scratch or prick method, is a rapid and minimally invasive diagnostic tool used to identify immediate hypersensitivity reactions that are mediated by immunoglobulin E, commonly known as IgE. When a small quantity of an allergen is introduced into the superficial layer of the skin, a sensitized individual's immune system responds almost instantly by releasing histamine and other inflammatory mediators from local mast cells. This reaction produces the characteristic wheal and flare response within 15 to 20 minutes, which manifests as localized redness, swelling, and itching. The redness or erythema results from vasodilation, while the raised wheal represents localized edema caused by increased capillary permeability. When these two appear together, they confirm a positive allergic response. A red, raised, itchy lesion therefore demonstrates that the immune system recognizes the allergen as a foreign substance, triggering a type 1 hypersensitivity response. The nurse compares the size of the wheal and surrounding redness against a control site to determine the strength of sensitization. The larger the area, the greater the allergic reactivity. It is also essential for the nurse to closely monitor for systemic complications such as urticaria, angioedema, or anaphylaxis, and to ensure that emergency epinephrine is readily available in the testing area. Another crucial nursing responsibility is to advise clients to stop taking antihistamines for at least 48 to 72 hours before the test, as these medications can suppress histamine release and cause false negative results. In contrast, numbness in option A would not occur because the scratch test stimulates histamine release, not nerve blockade. Pain in option B is unlikely, as the test is superficial and does not penetrate deeply enough to reach pain fibers. Pallor in option C, on the other hand, would indicate vasoconstriction rather than vasodilation, which is opposite to what happens in an allergic reaction. Therefore, localized redness, often accompanied by swelling, remains the definitive sign of a positive reaction. Transitioning now to the Stand-Coast clinical insight, let us reflect on the deeper meaning of this diagnostic tool. Every wheal and flare tells a story of immune recognition. The nurse's keen eye turns that redness into clarity, pinpointing the hidden allergens that shape a patient's life. Moving forward to the Stand-Coast high-yield NCLEX Pearl, remember these quick takeaways. Redness and wheal formation together confirm a positive allergic reaction. The mechanism involves IgE-mediated histamine release from mast cells. Discontinue antihistamines 48 to 72 hours before testing to prevent false negative results. Always have emergency epinephrine readily available in case of systemic reaction or anaphylaxis. Let us move into an important clinical safety scenario that highlights the nurse's crucial role in allergen immunotherapy. During allergen desensitization, a client receives weekly injections containing diluted allergen extracts to gradually build immune tolerance. Immediately after today's injection, the client stands up to leave the clinic. The nurse must decide which instruction is most essential at this point. The options are as follows. Option A advises the client to take a couple of aspirin before leaving. Option B instructs the client to wait at least 20 minutes before going home. Option C suggests ensuring that someone else drives the car. Option D recommends avoiding getting the injection site wet. The correct answer is option B. Wait at least 20 minutes before going home. Allergen immunotherapy, also called desensitization or hyposensitization therapy, works by exposing the immune system to gradually increasing doses of allergen extracts to build tolerance and reduce hypersensitivity reactions. However, even the smallest dose can trigger a systemic allergic reaction, ranging from mild urticaria to life-threatening anaphylaxis. For this reason, it is absolutely essential that clients remain in the clinic under observation for a minimum of 20 to 30 minutes after every injection. This observation period allows the healthcare team to detect and treat any adverse reactions immediately with emergency interventions, such as epinephrine, oxygen, antihistamines, or corticosteroids. In cases where reactions occur, symptoms such as generalized itching, cough, chest tightness, difficulty breathing, wheezing, dizziness, or hypotension may appear within minutes. Nurses must be alert, ensuring emergency equipment and medications are accessible at all times. In contrast, aspirin, as mentioned in option A, is contraindicated because it may aggravate allergic symptoms and cause gastric irritation or bleeding. The instruction in option C regarding someone else driving is not essential unless dizziness or hypotension occurs. Likewise, option D about avoiding wetting the injection site is not critical, as bathing does not interfere with the immunologic process or alter therapy effectiveness. The true priority is immediate observation for systemic reactions that can occur unexpectedly. Transitioning to the clinical insight, stand coast, Pearl. Before allowing any client to leave after receiving allergy desensitization therapy, the nurse's vigilance becomes their greatest protection. That short 20-minute waiting period may seem insignificant to a client, but it can make the difference between timely recognition and fatal delay in the case of anaphylaxis. A nurse's proactive observation during this window embodies the essence of patient safety. Transitioning to the stand coast high-yield NCLEX Pearl. Always ensure clients are observed for 20 to 30 minutes following allergen immunotherapy injections to monitor for potential anaphylaxis. Keep epinephrine and airway management equipment immediately available, and instruct clients to report any signs of itching, swelling, or shortness of breath at once. Never advise the use of aspirin after allergy injections. Remember, prevention through vigilant observation is the nurse's most powerful life-saving intervention. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Let us now look at another high-stakes nursing situation that demands sharp observation and immediate action. While monitoring a client who has a known history of allergies, the nurse carefully observes for the earliest indicators of an anaphylactic reaction after exposure to a suspected allergen. The question asks, which assessment findings should alert the nurse that the client may be developing anaphylaxis? Here are the options. A. Breathing difficulty, B. Headache, C. Sore throat, and D. Cool, pale skin. The correct answer is option A. Breathing difficulty. Anaphylaxis is a rapid-onset, life-threatening type 1 hypersensitivity reaction mediated by immunoglobulin E IgE antibodies. When a previously sensitized individual encounters the allergen again, such as certain medications, foods, latex, or insect venom, The allergen binds to IgE on mast cells and basophils, triggering a massive release of histamine, prostaglandins, and leukotrienes. These chemical mediators cause widespread vasodilation, increase capillary permeability, and smooth muscle constriction, especially in the respiratory and cardiovascular systems. The very first and most critical sign of anaphylaxis is breathing difficulty, which can present as wheezing, stridor, shortness of breath, or a feeling of throat tightness. This occurs due to laryngeal edema and bronchospasm that compromise airflow. Rapid recognition is essential because airway obstruction and circulatory collapse can occur within minutes. The nurse must immediately discontinue exposure to the allergen, call for help, and administer intramuscular epinephrine in the mid-anterolateral thigh, followed by oxygen, airway management, and intravenous fluids as prescribed. In contrast, option B, headache is nonspecific and unrelated to the allergic cascade, often resulting from dehydration or tension. Option C, sore throat may accompany infections, but is not a hallmark of acute hypersensitivity unless airway swelling is evident. Option D, cool, pale skin represents a late finding that emerges when shock develops due to systemic vasodilation and hypoperfusion. Therefore, it does not serve as an early indicator. Now moving to the Stancoast clinical insight, before a full anaphylactic crisis erupts, the body gives subtle warnings such as mild dyspnea, chest tightness, or coughing. The vigilant nurse who identifies these early cues and intervenes promptly can prevent catastrophic airway closure. Quick recognition and immediate action truly define life-saving nursing care. Transitioning to the high-yield NCLEX Pearl, always prioritize assessment of the airway and breathing in any allergic event. Keep epinephrine, oxygen, and emergency airway equipment within reach wherever allergens or injections are given. After administering epinephrine, monitor vital signs every 5 minutes, document all interventions, and offer calm reassurance, because reducing anxiety also eases bronchospasm and supports oxygenation. Let us move into another critical and time-sensitive nursing emergency that every professional must handle with precision and speed. During post-operative monitoring, the nurse observes that a client suddenly develops facial flushing, generalized hives, shortness of breath, and a rapid thready pulse after receiving an intravenous antibiotic. Recognizing these signs as an acute anaphylactic reaction, the nurse must act immediately. The question asks, which medication should the nurse prepare to administer without delay? Here are the options. A. Codeine sulfate, B. Morphine sulfate, Rationale, C. Dopamine, Intropin, and D. Epinephrine, adrenaline. The correct answer is option D, epinephrine, adrenaline. Anaphylaxis is a rapidly progressive and life-threatening systemic hypersensitivity reaction that can quickly lead to airway obstruction, circulatory collapse, and cardiac arrest if untreated. It represents a type 1 hypersensitivity reaction mediated by immunoglobulin E, IgE. Upon re-exposure to an allergen, such as certain antibiotics, contrast dyes, latex, or food, the immune system triggers massive mast cell and basophil degranulation, releasing histamine, prostaglandins, and leukotrienes. These chemicals cause intense bronchoconstriction, vasodilation, and increased capillary permeability, leading to swelling, hypotension, and hypoxia. Epinephrine, adrenaline, is the drug of choice in this emergency because it acts on both alpha and beta adrenergic receptors. Through alpha stimulation, it produces vasoconstriction that reverses hypotension and reduces vascular leakage. Through beta-1 effects, it strengthens cardiac contractility and heart rate, maintaining perfusion. Through beta-2 effects, it relaxes bronchial smooth muscles, reversing airway constriction. The preferred route is an intramuscular injection into the mid-outer thigh using a 1 to 1,000 concentration, with a typical dose of 0.3 to 0.5 milliliters. This should be administered immediately at the first indication of respiratory distress or circulatory collapse, because delay can be fatal within just 5 to 10 minutes. After giving epinephrine, the nurse should initiate high-flow oxygen, secure the airway, and start intravenous fluids to restore volume. Additional medications such as antihistamines and corticosteroids can be administered once the patient begins to stabilize. Continuous monitoring of cardiac rhythm, oxygen saturation, and vital signs is essential during this phase to prevent recurrence or biphasic anaphylactic reactions. Now let us review why the other options are incorrect. Option A, codeine sulfate is inappropriate because it is an opioid analgesic that depresses the central nervous system, potentially worsening respiratory distress and hypotension in anaphylaxis. Option B, morphine sulfate, Rationale, is also incorrect, as it can release histamine and aggravate the allergic response, causing vasodilation and further lowering of blood pressure. Option C, dopamine, intropin, though sometimes used for persistent hypotension after stabilization, does not relieve bronchospasm and therefore cannot reverse the airway constriction seen in anaphylaxis. It is not a first-line medication for this condition. Transitioning to our stand-coast clinical insight. In anaphylaxis, every second counts. The nurse who reaches for epinephrine first saves not just the airway, but the patient's life. Moving forward to the stand-coast high-yield NCLEX Pearl. Always ensure that epinephrine auto-injectors or emergency kits are readily available in any setting where allergens, antibiotics, or contrast agents are administered. The golden rule is simple: epinephrine first, oxygen next, and IV fluids soon after. Delayed epinephrine administration remains the most preventable cause of death in anaphylaxis. So act fast, act first, and act right. As we move forward into another emergency nursing scenario, let us consider a patient care situation that demands critical thinking and rapid assessment skills. A nurse is attending to a client who suddenly develops symptoms of a severe allergic reaction following an intravenous antibiotic infusion. The client presents with shortness of breath, widespread redness of the skin, a dangerously low blood pressure, and a rapid, thready pulse. In such a high-risk situation, which nursing assessment is most essential for evaluating how effectively the emergency treatment is working? Here are the options. Option A, measure the client's temperature. Option B, assess the client's skin color. Option C, monitor the client's blood pressure. And option D, check the client's pupillary response. The correct answer is option C, monitor the client's blood pressure. Now, let us understand the advanced rationale behind this. A severe allergic reaction, known as anaphylaxis, represents a life-threatening type 1 hypersensitivity reaction mediated by immunoglobulin E. This reaction leads to widespread vasodilation, fluid leakage from the capillaries, and constriction of smooth muscles throughout the airways, causing both airway obstruction and circulatory collapse. The most immediate threat to life during anaphylaxis is hypovolemic distributive shock due to massive vasodilation and plasma leakage into tissues. Therefore, the most critical assessment the nurse can perform to evaluate the effectiveness of treatment is continuous blood pressure monitoring, because it directly reflects circulatory perfusion and the body's response to interventions. When epinephrine, the drug of choice, is administered, it stimulates alpha-adrenergic receptors to produce vasoconstriction and elevate blood pressure, while its beta-adrenergic effects promote bronchodilation and enhance cardiac output. A noticeable improvement in blood pressure and peripheral pulse after epinephrine use signals that perfusion is improving and treatment is succeeding. However, if hypotension persists, it may indicate ongoing anaphylactic shock, requiring further epinephrine doses, intravenous fluid resuscitation, or vasopressor support such as dopamine or norepinephrine. Close blood pressure monitoring also helps the nurse accurately titrate oxygen therapy, fluid administration, and medications. In severe cases where peripheral perfusion is compromised, a non-invasive cuff may be unreliable. Hence, an arterial line may be used for continuous blood pressure measurement. This critical focus aligns with the ABCDE emergency approach: airway, breathing, circulation, disability, and exposure, where circulation assessment comes immediately after airway and breathing stabilization. Let us also clarify why the other options are not correct. Option A, measuring temperature, is not a priority in anaphylaxis because body temperature typically remains normal. Fever is not part of the allergic cascade and does not help evaluate the success of emergency interventions. Focusing on it may delay detection of life-threatening hemodynamic changes. Option B, assessing skin color, can provide some indirect cues about perfusion, but is subjective and easily influenced by factors like baseline skin tone or lighting. Improvement in skin color may accompany recovery, but is not a reliable indicator of circulatory stabilization. Option D, checking pupillary response, assesses neurological status rather than circulatory function. Unless the client progresses to respiratory arrest or profound hypoxia, pupils remain reactive. Therefore, this measure does not guide the nurse in evaluating treatment effectiveness during anaphylaxis. Transitioning now to our Stand Coast clinical insight. In anaphylaxis, the nurse's first duty after securing the airway is to follow the pulse and pressure, because blood pressure is the mirror that reflects whether life is returning or fading. And moving on to the Stand Coast high-yield NCLEX Pearl, always give top priority to blood pressure monitoring in clients experiencing anaphylaxis or any type of shock. Expect hypotension due to extreme vasodilation and plasma leakage, and continuously assess the impact of epinephrine, oxygen therapy, and intravenous fluids by tracking improvements in blood pressure, heart rate, and level of consciousness. Above all, never delay epinephrine administration while assessing. Initiate life-saving measures simultaneously. Let us move to an intense emergency scenario that tests both precision and presence of mind. A nurse is attending to a client who suddenly develops a severe anaphylactic reaction after receiving an intravenous antibiotic. Within moments, the client becomes unresponsive and pulseless. Acting swiftly, the nurse assesses responsiveness by shaking the client and calling their name, confirms the absence of a pulse, and immediately activates the emergency response system. Now the crucial question arises. What should the nurse do next? Here are the options. Option A, administer a single precordial thump to the sternum. Option B, deliver 2 quick rescue breaths with visible chest rise. Option C, begin high-quality chest compressions at a rate of 100 to 120 per minute. And Option D, administer intramuscular epinephrine in the lateral thigh. The correct answer is Option C. Begin high-quality chest compressions at a rate of 100 to 120 per minute. When a client becomes pulseless and unresponsive, the nurse must immediately initiate the basic life support sequence as outlined by the American Heart Association 2020 guidelines for cardiopulmonary resuscitation. Once unresponsiveness and pulselessness are confirmed, the next life-saving step is immediate chest compressions. This initiates the cardiac arrest chain of survival. Early, high-quality compressions create forward blood flow, sustain minimal cerebral and coronary perfusion, and significantly increase the likelihood of successful defibrillation and return of spontaneous circulation. Compressions should be performed at a depth of 5 to 6 centimeters, 2 to 2.4 inches, at a rate of 100 to 120 per minute, allowing complete chest recoil after each compression and avoiding interruptions longer than 10 seconds. The compression to ventilation ratio for a single rescuer remains 30 to 2. While epinephrine is a vital drug in anaphylaxis, in a pulseless client, mechanical perfusion through CPR always takes precedence. Drug administration, including intravenous or intraosseous epinephrine, follows once compressions have started and vascular access is secured. Now, let us understand why the other options are incorrect. Option A, administering a single precordial thump, is not recommended in unwitnessed arrests or anaphylaxis-related cardiac arrests. It may waste precious seconds and cause harm. Option B, delivering 2 quick rescue breaths, contradicts the CAB sequence, circulation airway breathing, that prioritizes compressions before ventilation. Rescue breaths should follow after the first 30 compressions. Option D, giving intramuscular epinephrine, is appropriate for anaphylaxis, when the client still has a pulse, but not in a pulseless situation. In cardiac arrest, intravenous or intraosseous epinephrine is given every 3 to 5 minutes, only after CPR has begun. Transitioning to the deeper clinical reflection, Stand Coast. Clinical insight. In cardiac arrest, oxygen delivery depends first on compression, not medication. No drug can move blood through a motionless heart, compressions do. And now for your ultimate takeaway. Stand Coast High Yield, NCLEX Pearl. Always follow the CAB sequence for unresponsive clients. C for circulation. Start chest compressions. A for airway. Open and check for obstruction. B for breathing. Deliver rescue breaths after 30 compressions. Immediate CPR within the first minute of collapse can double or triple survival rates, while even a short delay beyond 2 minutes can drastically reduce neurological recovery. Thank you for watching. See you next session.